Okay, so GYN procedures and vaginal hysterectomy. So for our indications, total vaginal hysterectomy, so that's TVH, is a good operation. It's not done all that commonly. I only saw it a couple times on my rotation. That's mainly because laparoscopic procedures have become a lot more common. And when you do a TVH, you lose some of the standard benefits that come with doing things laparoscopically. And the main ones are less time in the hospital after the operation and also less pain. But versus a total abdominal hysterectomy, TVH, total vaginal hysterectomy, is recommended because TVH has been shown to have less infections and also less pain than total abdominal hysterectomy. Some of the contraindications when you wouldn't want to do this are with cancer, mainly because you can't explore the abdomen at all and see what's going on, and then also size of the uterus. So if you have a really big uterus, you might have a problem delivering it through the vagina. And you also might have problems because you're working sort of along the side of the uterus trying to access, for example, the uterine artery and the cardinal ligament off to the side of the uterus, and that might be difficult just space-wise if the uterus is really big. And the indications, these are the same as in general for hysterectomy. So a leiomyoma, what would be alternatives to hysterectomy for that? I can think of two different ones. So one of them would be myomectomy, and the other one would be uterine artery embolization. So pelvic organ prolapse, you could try a pessary or pelvic floor strengthening exercises. For pain, let's say you have pain caused by something specific like endometriosis. What's medical therapy for that? GnRH analogs, you could use those. And if you have abnormal bleeding, you might want to try ablation of the endometrial lining before you proceed to something like hysterectomy. So for the anatomy review, we have the peritoneum coming down, sort of draping over the uterus, extending out towards us, forming the broad ligament to the lateral wall, reflecting up anteriorly onto the bladder, forming the vesico-uterine fold here. This is anterior cul-de-sac, and then the posterior cul-de-sac back here. And then you get the bladder anteriorly, rectum posteriorly. Here's the vaginal opening coming to the cervix and then uterus. So you might have to do a bimanual exam before the operation, and if you do, you're going to want to report something when you're done with it, so you don't just stand there with nothing to say. And what you're going to want to say is what you think the version and the flexion is, which are terms to describe the position of the uterus here in the pelvis. So the version is the angle of the uterus with respect to the vaginal opening. So the way I've drawn it here, if you're pushing up on the cervix and you're feeling the abdomen with your other hand, and you can feel the uterus bumping up against your hand, then it's probably anteverted, which is the way it's shown. If you can't feel anything, then it might be retroverted, like this. And so then you wouldn't be able to feel it when you're pushing. So that's version, the uterus with respect to the vaginal opening. And then you have flexion, which is the uterus with respect to the cervix. So let's say we're going up here like this, like we're anteverted, but then we branch off this way. That would be anteverted and anteflexed. So continuing along with the anatomy review, we have the arterial supply. So we have abdominal aorta dividing up into common iliacs. And then we have the common iliacs further dividing into the external and the internal. And so the external, what does that become after the inguinal ligament? That becomes the femoral, and the internal divides up into anterior and posterior divisions. Then we'll put the uterus in just to get oriented. And off of the anterior division of the internal iliac, we have what matters to us, which is the uterine artery. There's also the vaginal artery, the umbilical artery, and some other important ones that come off of this division of the internal iliac. So the ureter, where does that go? So that's coming down from the kidney up here. It crosses on top of the common iliacs just before it bifurcates into the internal and external divisions, and then comes down, runs almost alongside the uterine artery, and then passes underneath the uterine artery. So that's where the water under the bridge comes from. And just for general knowledge, where does this division happen? Where does the abdominal aorta divide up into the common iliacs? That's at the navel, so that's T10 at your belly, butt 10. And lymphatics and embryology. So you have the uterus and part of the vagina. Where does that come from, embryology-wise? Those are Müllerian structures, and the lymphatics that serve them are the internal and external nodes, and ultimately the common iliac nodes up here. And so you have the distal vagina. Where does that come from, embryology-wise? That's from the urogenital sinus, and that goes over here to the inguinal nodes, and the inguinal nodes are over by the femoral artery, which is near the inguinal ligament. And the last layer of anatomy to add is the ligaments. That's the important thing I want to put in here. So you have the blood supply to the ovary, so that's coming right off the abdominal aorta, and that travels in a ligament called the suspensory ligament of the ovary, and that's the way it was in years 1 and 2 of school. But then on the rotation, that became the infundibulopelvic ligament. So if you hear people talking about the IP, That's what they're talking about. That's the suspensory ligament of the ovary, and it's bringing the blood to the ovaries. Then you have the uterine artery. What does that run in? That runs in the cardinal ligament, coming up from the lateral wall of the uterus. And then you have the uterosacral ligament, and that sort of meets up with the cardinal ligament, forming the uterosacral cardinal complex attaching here to the uterus. But the uterosacral, where does it come from, or where does it go, depending on how you're looking at it? And it goes posterior and inferior to the ischial spine and the sacrum. So that's sort of providing anterior posterior support, whereas the cardinal is providing more lateral support. Then you have the round ligament here. What travels in the round ligament? It's like a PIM question type of thing. That's Samson's artery. Goes in there. And so where's that headed to? That's headed to the labia majora. And then where does it travel in important places? The internal ring of the inguinal canal. So the only other ligament to add is an easy one because of the way it's named. It's the utero-ovarian ligament. So that finishes off the anatomy review. So now move on to the procedure. So pre-op, your standard sort of setup, cephalosporins, get them in a half an hour before. If somebody has asymptomatic bacterial vaginosis, you have to treat it, which means you have to test for it because you treat it even if it is asymptomatic, and you use Metro to treat it, and along with that you get the disulfiram reaction, headache, metallic taste. NG tube, so that's important to keep air out of the intestines, which helps prevent injury to the bowels. Foley, I didn't see those used. I think it's plus or minus on those. Cancer screening, you want to do this for everybody with hysterectomy, so you want to make sure they've had a pap smear recently in the couple months leading up to the procedure, and if it's age appropriate, greater than 40 or 45, depending on the guidelines, mammography. Endometrial cancer, let's say you're worried about that, there's some abnormal uterine bleeding or something, you'd want to investigate that with the DNC and directed biopsy of the endometrial lining. DVT prophylaxis, so the standard setup, the heparin and the PCD boots, and then the patient's supine and stirrups, and you're ready to get going with the procedure. So the general idea is for this, because there's lots of different ways to do it, and everyone will do it differently, but and it's important to know the general idea. So you want to get inside of the peritoneum, and you have to go do that by getting access anteriorly, so that's between the vesico-uterine fold, and then posteriorly, that's getting into the posterior cul-de-sac. Then you want to free up the uterus from its attachments to the peritoneum, like the broad ligament, and also disconnect it from its blood supply. So that'd be the uterine artery, and then the uterovarian or IP ligament, depending on what you're doing with the upper vascular pedicles. And then you can keep or remove the ovaries, and then you want to re-peritonealize and create a vaginal cuff. So now we'll go through step by step just to get a little bit more detail and sort of show an example. So the first thing is positioning the patient. So they're in dorsal lithotomy position, so like this. And so what goes along with that is you're flexing the hip. And so what damage could that cause, or what adverse event could that cause? It could compress the femoral nerves, specifically the femoral cutaneous nerve L2, L3, which could cause anesthesia to the anterior part of the thigh after the procedure. And then, so at the knee, what damage or patient positioning issue could come up with there? There could be compression of the perineal nerve there. Okay, so that's that. And then when you start out, you might inject vasopressin into the cervix, and that's to prevent bleeding. So remember, vasopressin, that's ADH, the V2 receptors helping put the aquaporins into the collecting tubules. And then also at high concentrations is what you use here, so that's why it's called vasopressin, pressing those vessels to prevent bleeding. All right, so in terms of the actual procedure, the first thing that you might do is incise around the cervix here, at the sort of the junction of the cervix and the vagina, and then you want to gain anterior access. So you have to dissect away between the bladder and the uterus until you get to the vesico-uterine fold. And we'll go back up here to look at this picture to get an idea about that. So you're working here, you're dissecting away here, working your way up to the vesico-uterine fold. You'll probably use a retractor, like a right angle retractor, to pull up on the bladder to sort of get it out of the way. And then when you find the vesico-uterine fold, which would be like a little white line, you can pick it up with pickups and then incise it with Mayo scissors, and then you've gained access to the anterior cul-de-sac, so you've made a hole in the anterior peritoneum. And then you can turn your attention to the posterior side, and luckily the posterior peritoneum is actually really close. You can see right here where you are, sort of the junction of the cervix and the vagina, the posterior peritoneum is close there, so you just incise that. And so now you've gained access anteriorly and posteriorly inside of the peritoneum. So you've done that, so now you can start to work on disconnecting the uterus from the ligaments and its blood supply. So the first thing will be you want to take a bite of the uterosacral ligament, and so you can use Heaney clamps to grab it, and you want to grab, you want to stay real close to the uterus, so you grab real close, cut, take a bite, and then you're moving up. So what's the next thing you're going to run into? The next thing will be the cardinal ligaments, so you can bite those, clamp them, cut them, make vascular pedicles out of those. Keep working your way up the broad ligament, and now you've sort of loosened up the uterus from a lot of its attachments, and you can walk its way out a little bit. And you have to, and then once you've done that, I'll just put on what we've done to summarize. So uterosacral, we dealt with that. Cardinals, we made that vascular pedicle. We've worked our way up here along the broad, and so now depending on what's going on with the ovaries, we can decide what to do next. And so I'll put in the uteroovarian here. So let's say we're going to take the ovaries, keep the ovaries inside. So then we could cut the round and uteroovarian, and then we could remove the uterus. So we're grabbing the uterus here, we're pulling it out of the hole we've created by slicing around the cervix. And let's say that we're gonna take the ovaries with us instead. What would we do there? Well, we could start by doing the same thing. We could cut the round uteroovarian. We could tag the uteroovarian with some suture. So we remove the cervix to get it out of the way, and then we grab the tag that we put in here in this ligament, pull on it to put some tension on it and help us identify infundibulopelvic. And remember, the infundibulopelvic is the suspensory ligament of the ovary bringing the blood to the ovaries. So we want to find that, and then we want to cut that, and then we can remove the ovary. So now what's left is re-peritonealization and making the vaginal cuff. So re-peritonealization, that's putting the peritoneum back together. So we cut the peritoneum anterior at the vesicouterine fold, posteriorly, and then also as we worked our way up, we took different bites out. For example, this might be the uterosacral ligament, part of the broad ligament. Maybe this is tubo-ovarian ligament. So when you re-peritonealize, you take a needle and suture and you sew these back together to bring them back together with each other. And so that's shown over here. Now they're close together. And you do that to recreate the structure and support that the peritoneum provides in the pelvis. And then so once you do that, then you want to make the vaginal cuff. And again, you have suture in your string. You're closing off the vaginal cuff, and you can get little bites of, for example, let's say this is uterosacral ligament. You can get bites of that as you're working, and that'll help provide some structure and support to prevent complications. For example, things like enteroceal. So that's why you want to. That's why they take the time to do all this suturing. All right. So complications. So we have the standard complications that come along with doing hysterectomy: fever, hemorrhage, injury to the bladder or ureter. Although we noted that this is, at least a study showed this to be less common doing it vaginally than laparoscopically. Bowel injury, cuff dehiscence. So that's the cuff that we just talked about sewing closed. If that doesn't sew closed all the way, or if it comes open and some bowel goes through it and his blood supply gets cut off and gets strangulated, that's vaginal cuff dehiscence with potentially evisceration, which would be sort of a serious, rare, but unique complication of this type of operation. And the cuff can also get infected. So then you have the general surgical complications, MI, stroke, renal failure, and then common sense things like you want to avoid vaginal intercourse for some time after this procedure. So the post-op, you have the standard setup. Don't need antibiotics after day one. You put a Foley in sort of after you do this procedure if you didn't have one in during it. You get some fluids, DVT prophylaxis till the person's walking around. You can ambulate them day one post-op, get people walking around. And you advance the diet from water to clear liquids to regular, depending on flatus, appetite, and bowel sounds. And so questions, things that I got asked during this procedure. So what space are we entering? So that's in the beginning of the procedure. So if you're below the cervix, you're probably entering the posterior cul-de-sac. If you're above the cervix, then you can say, I think we're entering the anterior cul-de-sac going through the vesicouterine fold. So why do you have to clamp and cut the ligaments and vessels right next to the uterus? You do that because you want to avoid injury to the ureter. So unlike doing this laparoscopically or abdominally, you can't really see what's going on as well. So you can't identify the ureter, watch it peristalsis, and then cut. So you just want to avoid injury by keeping a close eye on where you're working. And then questions that you could ask if they notice a difference in complications. Do they think that, for example, there's less injury to the ureter by doing this? Also, you could say, what makes you select vaginal versus laparoscopic? Why are we doing this vaginally? Things that could favor a vaginal approach would be someone who's um, has had multiple children, someone who has a uterus that's small. Those are things that might favor a vaginal approach. And then laparoscopic assisted vaginal hysterectomy. I didn't see those. You could ask if they do those frequently, um, and what sort of indications would make them want to do that. And you could bring up things like if you're having trouble with getting the ovary out or accessing the infundibulopelvic ligament, would you want to do would you want to add laparoscopic assistance to the procedure to help make that happen? Okay, so that's our summary of vaginal hysterectomy.